Good afternoon. The primary aim of this study is to characterize the association between urinary incontinence and skeletal fragility defined by a combination of quality and quantity bone assessment. And the secondary aims include to examine the impact of bone quality and quantity separately on pelvic floor symptoms, as well as the association with FI and pelvic organ prolapse. Postmenopausal women undergoing osteoporosis evaluation from 2007 to 2010 were included in this analysis. Urinary incontinence was defined as the leakage of urine at least 2 to 3 times a week. And types of urinary incontinence were defined by the validated questionnaire, the 3IQ. Fecal incontinence was the liquid or salt stool leakage at least once a month. And pelvic organ prolapse was defined using the PFDI-20 prolapse question. For the primary aim, skeletal fragility was defined as a combined bone quality and quantity index, which is equivalent to the moderate to severe fracture risk based on the current literature. And for the secondary aims, low bone quality was defined using trabecular bone score, and low bone quantity was defined using the traditional WHO criteria with a bone mineral density. Of 681 subjects, no difference in demographic characteristics were noted between groups except for age and the smoking status. For the primary aim, using the combined criteria, women with skeletal fragility had a higher rate of NEUI as well as stress urinary incontinence. And skeletal fragility was independent risk factor for NEUI as well as stress and mixed urinary incontinence. Using the trabecular bone score criteria, women with low bone quality had a higher rate of all types of urinary incontinence. And the low bone quality was independently associated with all types of urinary incontinence. However, using the bone mineral density criteria, no difference was noted between groups, and low bone quantity was not associated with pelvic floor symptoms. The strength of our study includes the robust sample size of nearly 700 postmenopausal women, and a detailed pelvic floor symptom characterization was obtained using the validated measures. The novelty of this study includes the skeletal integrity was assessed by bone quantity and quality index to increase the accuracy of bone evaluation. In conclusion, skeletal fragility defined by the combination of quality and quantity measures as well as poor bone quality were independently associated with increased risk of urinary incontinence. There may be a pathophysiologic link between skeletal fragility and urinary incontinence sharing a common underlying mechanism. Thank you.
The floor is open for discussion. Heidi?
Heidi Brown, University of Wisconsin. U.S. Very nice study. Thank you so much for sharing your work. Do you have any hypothesis about why UI both urge and stress, but not FI or prolapse?
So, the continence mechanism is provided by or maintained by the pelvic floor support, which is consistent of pelvic floor muscle and connective tissue that are attached to pelvic floor, the pelvic bony structures. And so that if there is a abnormality in collagen metabolism, that would lead to pelvic floor support, a pelvic floor dysfunction, poor pelvic floor support leading to any type of pelvic floor dysfunction. So I was surprised with the results as well. Maybe the collagen and abnormality of collagen metabolism might have more impact on the urinary incontinence compared to fecal incontinence and pelvic floor support. But we are looking into the abnormal collagen metabolism and its association with the incontinence and other pelvic floor disorders.
I think this is something, this study, I go to a completely different issue, I think this study is a good example for us to discuss at the next international consultation on incontinence, because we should actually maybe use not these outcomes. And I know I'm pretty critical, but when we are clinicians and we do diagnostics, we want to know whether the person has SUI, UUI, or mixed, because we treat them differently. But when we look for risk factors, there's one disease called stress urinary incontinence. There's another disease called urgency urinary incontinence. They just happen to be same time. And in my view and my world of thinking, we should look for risk factors for these two, but never for the mixed. I know a lot of world leaders do that. There's a great, excellent group what you're having, and you do it. But we should discuss whether we should do risk factor analysis on mixed, where we would just look separately stress and urgency. What do you think about that?
Definitely, because the intervention, so the goal of this study is, first we need to identify the association, but the ultimate goal is to come up with the intervention or the management algorithm. So because the stress in mixed urinary incontinence or the urgency, the algorithm would differ. So definitely we are looking these conditions and subtypes separately to see what really, is there any association was our first question, but is there a stronger association with certain types of urinary incontinence or fecal incontinence and the other pelvic floor disorders. But, the reason that I did this study is out of curiosity, but also compared to urinary incontinence, the other chronic conditions such as osteoporosis, falls, frailty, fall risks, they have a very established protocol or the management algorithm. So if there is a association, maybe we can look at it from a global perspective or point of view. But thank you for your comments.
Thank you for your work. Thank you.
Thank you.